Exercise Theory, Chapter 5, Exercise Physiology. We're going to start off talking this chapter with our cardiovascular system. It's also called the cardiorespiratory system because our cardiovascular system will deal with our circulation and our respiratory systems. So our heart, our blood vessels, as well as our lungs. So these two systems work together, and they are going to work to deliver oxygen and nutrients to the body. And so when we're exercising, they will get oxygen, nutrients to our working muscles. They will exchange the oxygen and nutrients at the muscle cells, and it will take away the waste products, especially carbon dioxide, which it will return to the lungs. The lungs will expel the carbon dioxide and bring in more oxygen. Now, the reason we talk so much about the cardiovascular system, it does work all the time. It's what keeps us alive. But exercise will specifically challenge these systems, because when we exercise, our need for oxygen at the working muscles goes up dramatically. Because it goes up dramatically, our heart and our lungs have to respond to meet these needs. The circulatory system is responsible for transporting materials through the entire body. So as I've mentioned already, it will transport nutrients, water, and oxygen, as well as the waste products such as carbon dioxide. So oxygen is going to the working muscles and to the tissues of the body, and carbon dioxide is brought away from. So here is a general picture of our circulatory system. What you are going to be looking at here is the heart, as well as the arteries and veins. You'll notice the heart in the center. You can see that it's 4 chambers. You have a right and a left side of the heart. Those are different systems that pump blood in different directions. You'll also notice on the diagram that at the chest level, the level of the lungs, you're seeing a series of endings of arteries and veins, and those are the ones that are going to the heart, to the lungs, for the pulmonary circulation. So that's going to take the blood to the lungs to drop off carbon dioxide and to pick up more oxygen. So let's do a little talk while we have a diagram in front of us, and I encourage you, please have your textbook open and ready to go, because in the next few slides we'll continue talking about this system, but you may not always have a visual to refer to. I find it works much better if you can see a picture while you're hearing the words. So looking at the heart, you can see that there's 4 chambers. The last chamber is covered a little bit by your aorta, so it's a little harder to see. But what will happen is blood will come from the body, and it'll come into your right atrium. Your right atrium is in the top left corner of the heart diagram, because you have to remember we're talking it right as it's on the right side of the person whose heart it belongs to. So on the top left corner is your right atrium. The blood will come from the body. This is going to be blood that does not have much oxygen left in it because it's returning to the body with carbon dioxide. It's returning via veins. It will go into your right atrium and then get pushed down into your right ventricle. The ventricles are the 2 chambers on the bottom of the heart. The atria, or the individually atrium, are the top chambers in the heart. So it will go from the right atrium to the right ventricle, and that right ventricle will contract, and it will send that deoxygenated blood, so blood without oxygen, to the lungs. In the lungs, on its way to the lungs, it is going to go from arteries to arterioles, down to our smallest blood vessel, which are capillaries. These capillaries will come into contact with the alveoli, which are little air sacs in the lungs. So again, the capillaries will come into contact with the alveoli in the lungs. The blood from the capillaries will dump carbon dioxide into the lungs, and it will pick up oxygen. And it does this for multiple purposes, or multiple reasons. It has to do with pressure gradients and concentration gradients. and how hemoglobin will act at the lungs. So once again, at the lungs, a capillary will come into contact with an alveoli, the smallest of the vessels and the smallest of the cells of the lungs, and the circulatory system, so the capillaries will dump carbon dioxide into the lungs and pick up oxygen. The capillaries then become bigger and they become venules, and then they become larger again and become veins, and that vein will return with oxygenated blood to the heart. This time it will return to the left atrium, and that's the square that's the hardest to see. So in this diagram of the heart, it would be pretty much the upmost chamber. Okay, so it's your left atrium, and it'll get pushed into your left ventricle. Now remember, this is stuff that's returning from the lungs, so there's lots of oxygen in this blood. That left ventricle will contract. Blood will exit the heart through the largest of the arteries, which is your aorta. You'll hear them talk about your aorta. From there, it'll get pushed into more and more arteries, and the arteries will gradually get smaller. They'll look like branches, gradually getting smaller. So it goes to more and more arteries until it goes to arterioles, which are very small arteries, and then it goes into capillaries. Capillaries are very, very thin-celled, so they're single-celled. They're single-celled walls, and this is going to now allow gas exchange to occur at the muscle tissues. So at the muscle tissues, the blood, which has oxygen in it, will push oxygen out into the muscle tissue, and the muscle tissue in turn will dump carbon dioxide into the blood. So at the capillaries, at the muscle fibers, we will be getting rid of oxygen to give oxygen to the working muscles and picking up the waste material of carbon dioxide. So this occurs at the capillaries. At the end of the capillary bed, you reach the venules again, and then they'll get bigger and bigger until you're back into the veins. These will travel back to the heart. You'll have the superior vena cava and the inferior vena cava. These are just the largest veins as they arrive at the heart. They are carrying deoxygenated blood because it's blood returning from the body. They will go into your right atrium, into your right ventricle, which is deoxygenated blood. The right ventricle will contract, and it will send that deoxygenated blood to the arteries that are going to the heart, the pulmonary artery, or no, the heart, pardon me, to the lungs. So they're going to go into the pulmonary arteries towards the lungs, to the pulmonary arterioles, to the capillaries to do gas exchange with the alveoli of the lungs. So the capillaries will dump carbon dioxide into the lungs, pick up more oxygen. It will loop back to the heart through the venules, through veins. So when it reaches the pulmonary veins, it will end up landing in the left atrium with oxygenated blood, move into the left ventricle, and then the left ventricle will contract, sending the blood through your aorta into your arteries. This is all oxygenated blood. Arteries will move into arterioles, which will reach capillary beds, which are thin-celled walls. So the carbon dioxide and oxygen will exchange at these capillaries in the muscle fiber. We will dump the oxygen to the muscle fiber, pick up carbon dioxide, then we'll move into venules, veins, the inferior or superior vena cava, back to the heart. So what's really happening here? Any vessel that leaves the heart is always an artery. So you always will move from an artery to an arteriole to capillaries to venules, veins, and back to the heart. So the venules and veins are always what are returning blood to the heart. The capillaries are always where we have gas exchange, either at the lungs or the tissues of the body. Other things to kind of note is your right hand circulation is your pulmonary circulation, and it takes deoxygenated blood to the lungs. It picks up oxygen and returns it to the heart to go into the left side of the heart to go into your circulatory system, so it gets sent to the body. So when I picture the heart and the circulatory system and the pulmonary circulation, I picture loops. So there's a small loop from that right side that's going to go collect blood from the lungs, return to the left side, and then that one does a big loop through the body, returning to the right side again. We're going to talk a lot about this. I want to give you this general overview, and now I'm going to point all these things out individually. So here's just a diagram of what we just talked about. So now you'll see it all listed. There's your right atrium and right ventricle, and the left atrium is just a little harder to see, and the left ventricle. Remember, the deoxygenated blood returns from the body through the veins into your right atrium, gets pushed into your right ventricle, and the right ventricle is going to serve as a pump to send that deoxygenated blood through the pulmonary arteries to the lungs. It will pick up oxygen in the lungs and dump off carbon dioxide. It will return back with oxygenated blood to the left side of the heart, the left atrium, into the left ventricle, and the left ventricle is what's going to give it a large contraction and send blood out through your aorta, through the body, through your arteries, your arteries. Gas exchange will occur at your capillaries and muscle tissues, go to venules, back to veins, back to the heart. So here it's just saying that the heart acts as two separate pumps. The left side will pump the oxygen-rich or oxygenated blood through to the tissues of the body. This is your systemic circulation. The right side pumps oxygen-depleted or deoxygenated blood through the lungs, which is our pulmonary circulation. So this is just repeating what we've already said, so this should now be review for you. Deoxygenated blood enters the heart from the body, enters into the right atrium. It'll actually move from the right atrium to the right ventricle. The right ventricle will contract and push that deoxygenated blood to the lungs. In the lungs, the blood is oxygenated and returns to the heart through the pulmonary veins into the left atrium. It'll move from the left atrium into the left ventricle. The left ventricle will serve as the pump, and it will pump it out through the arteries, and then it'll return back to the body through the veins after gas exchange has occurred. So arteries always leave the heart, veins always return to the heart. So what makes the heart beat? It's actually part of our autonomic nervous system. So this system is systems that work involuntary. So we don't have to remind ourselves to beat our heart. We don't have to be like, oh, contract, contract, contract. Skeletal muscle that we talked about, that's voluntary. We can choose to contract or relax our skeletal muscles, but the heart will happen automatically, and it's actually got its own conduction system that you don't really need to worry about. It happens on its own, and that electrical stimulus will cause those ventricles to contract to drive blood throughout the body. So let's just continue looking at these different things we've already spoken of. So the blood will leave the heart, blood leaves the heart with oxygen through the aorta, and that is the largest artery in the body, and then it branches into smaller and smaller arteries, okay, and it'll keep branching down until it reaches the arterioles. It's important to note that the walls of the artery are thick and elastic, so this is why we can feel a pulse. When you feel your pulse, you're actually feeling a bolus of blood that was ejected from the heart push through that artery, and when it pushes through that artery, it stretches and you get an elastic recoil. That's what you're feeling, the pulse, because when your heart sends blood out, it sends it out in waves, and that gives us our pulse. So the walls of the artery being elastic will enable them to expand to accommodate the volume of blood expelled in surges from the heart. And then during relaxation of the heart, so in between the beats, the elastic recoil of that artery will force the blood forward. Okay, so remember, arteries have elastic in them. They will stretch out as the bolus and surge of blood comes to it, and then it will elastic recoil, sending the blood forward. This is how we move blood along. So we're going to be going from arteries to arterioles. It just means small artery. And into that we go into our capillaries. And we'll talk about these as capillary beds. So they're thin-walled vessels. They're single-celled vessels, and they will permit the exchange of gases and nutrients between the blood and the tissues. Okay? We will call this the microcirculation. After this exchange has occurred, the blood keeps moving through those capillary beds and will return to venules, which are very, very small veins, and carry on to the veins, returning to the heart. So in your systemic circulation, the blood will drop off oxygen and pick up carbon dioxide because it's interacting with muscle fibers and organs. In your pulmonary circulation, it does the opposite. So that's where you're taking the deoxygenated blood to the heart. You're dumping off carbon dioxide through your capillaries and picking up oxygen. So veins. After the blood has flown through that arterial network and through the capillaries, there's a collection system that will return it to the heart, okay, the blood to the heart. And this is our venous return. Veins have thin walls, so they're not able to push blood as effectively. What is unique about veins is that they actually have a one-way valve, and we will see a better diagram of this. But as the blood is pushed up, you have these valves that will close to prevent the blood from falling back down towards your feet or hands. So the blood gets pushed up, and then it's prevented from falling back down. These valves can be faulty, and that's where you get varicose veins from. So when you have people have that bulging in their vein, especially in their calves, you usually see varicose veins. That is just the valves didn't function properly, and it's allowing blood to pool in those veins. This is a really nice picture. So this is a vein returning with blood cells up to the heart. And as you can see, when the blood goes up, those valves will push through the valves, and the valves will close, so it can't fall back down. So what happens when we're at rest, our heart beats slower, and so our body is able to easily return. The pressure from that artery system will give enough push to push things through our veins as well. When we exercise, our demand for oxygen at our working muscles will increase, so our heart rate will increase. So our heart rate will start to beat quickly. It'll send blood to the capillaries. And because we're moving and we're doing movement when we exercise, what will happen is our contracting muscles will squeeze and milk the blood back up the veins. So muscular contractions will help drive that blood up towards the heart. Okay, so it'll cause a milking kind of action. So that works wonderfully. So we're exercising, our heart's beating very fast, we're helping return blood to our heart because we are doing movement of our muscles. What happens when we stop exercising suddenly? So let's say you're jogging, you're running really fast, and then you stop, and you completely stop. Your heart's still beating quickly, so it's able to quickly send the blood out to the working muscles. And it does that very, very quickly, very rapidly. But now that you're not moving, then the blood is not being pushed back to the heart with the contraction of the muscles. So the muscles are no longer contracting because you stopped. The blood all pools in the extremity. So when the blood pooling occurs, it'll cause a decrease in your blood pressure that's perceived right at the heart. Because the body doesn't realize that what's really going on, it doesn't realize that, oh, well, the blood's just in the extremity, the body is going to assume that you have a problem with your blood pressure, and that what it will do is it will give you a burst of adrenaline, that's norepinephrine, adrenaline, to boost your heart up, right? So it's going, oh, blood pressure is really, really low. We need a boost to the heart to increase our blood pressure. So it will give norepinephrine, also known as adrenaline, a big jolt to the heart. This is where people can have cardiac incidents. This is where they can run into trouble and have heart attacks or trigger issues. So see, once again, when you exercised, the movement helped return blood to the heart. If you stop too suddenly, the heart's still beating very quickly, blood will pool, your body will detect a decrease in blood pressure around the heart because the blood's now all in the extremities. It will give a burst of adrenaline, or norepinephrine is the term they're using here, that will try to jolt the heart to increase the blood pressure. If the person is prone or susceptible to any kind of heart issue, this can result in something very, very negative occurring. If we do a nice normal cool down, so if instead of stopping suddenly, we decrease the intensity of our movement, so say we were running, we go from running to walking, well, our muscles are still moving. They're still milking that blood back to the heart. And as a result, the muscles help return the blood to the heart. As the heart slows down, the heart will slow down gradually. You do continue to movement, and then everything will normalize. You won't have this problem. So carrying on, it just says that this high level norepinephrine can cause cardiac problems for some individuals. And we prevent this by keeping your participants moving after that higher intensity cardiovascular portion of the class. So we do a proper cool down. This is why a cardiovascular cool down is so important. It is there to prevent venous pooling or blood pooling. So next we have the respiratory system. This is how we're going to take oxygen into the body so that the circulatory system can pick it up and send it through the body. So we take air in through the nose. It's going to go into the pharynx, the larynx, the trachea, into the bronchus, and into the lungs themselves. So the respiratory system, so the purpose of this system is to provide a means of supplying oxygen and removing carbon dioxide. So we inhale oxygen, and then we are going to move that oxygen down through our lungs into our alveoli. Alveoli are the smallest cells in the lungs, and the capillaries from the circulatory system are going to allow gas exchange. So pulmonary ventilation is a process of moving air in and around the lungs. Air enters through the mouth or nose, passes the pharynx and the trachea. Beyond the trachea, it's going to divide into the bronchi and then further divide into bronchioles. And these bronchioles are going to divide into alveoli. There you can see the word alveoli, which are tiny sacs that are surrounded by tiny blood vessels, which are your capillaries. Now, the reason this all works, and I've already kind of alluded to this, is that oxygen is going to be moving from areas of high pressure or high concentration into areas of low pressure or low concentration. So in the case of the lungs, it's going to move, you have inhaled in oxygen, so the pressure and the concentration of oxygen within the alveoli is high. Because the capillaries are returning blood that has carbon dioxide, the volume and pressure and concentration of oxygen in the capillaries is low. So blood will enter from the alveoli, oxygen will go from the alveoli into your capillaries at the lungs. Hemoglobin is what we're going to attach that oxygen to transport it throughout the body. It's worth mentioning too, we have something called our ventilatory threshold. Our ventilatory threshold is the intensity of exercise above which your breathing becomes labored and you feel like you cannot draw in as much air as your body wants. So the demands of oxygen at your working muscle increase so high that you have to start breathing very rapidly. You're trying to rapidly do gas exchange. And you get to a point that the amount of lactate buildup in the working muscles increases so high that it's going to change the acidity in the body. So you're trying to breathe off enough acidity to change the acidity within the body. And as a result, you find you can no longer breathe. So the ventilatory threshold is closely linked with your lactate threshold, okay, the amount of lactate in the body. And just like the breathing rate, your blood lactate concentration can increase gradually, and then all of a sudden it increases much more rapidly, which is your ventilatory threshold. So it is, since we understand how important oxygen is to our working muscles, it allows us to produce activity and where it's necessary for life. It's important to know too what can reduce the amount of oxygen in the blood. And this is where iron plays a huge role. So I'm sure most of you have heard about problems with iron-related deficiencies. And the iron is going to be important with the hemoglobin. And so if for some reason you don't have as much iron in your blood as you should have, it's going to affect your hemoglobin levels, which will affect how much oxygen you can transport in your body. And individuals that may have an issue getting enough iron in their diet are going to be especially women who might eat poor diets, that are endurance athletes, that experience heavy menstrual flows. They might have lower iron levels afterwards, are pregnant or breastfeeding. Those individuals have issues with iron levels, or are vegetarian. I'd highly recommend, if you have reasons to suspect that somebody has low iron levels, send them to their medical doctor. Let their medical doctor do blood work. It's not really recommended just to up and start taking more iron. It's not always a desirable thing. So you do want to let a medical doctor control this, because perhaps they're fatigued, because usually people with low iron levels will experience a great deal of fatigue. They become anemic and they are absolutely exhausted. And so you really want to confirm that is the real reason, okay? But be aware of these individuals. So if you do have a female who is an endurance athlete, you want to make sure that they have a full, complete diet. If they are vegetarian, you want to make sure that they are taking in natural sources of iron to decrease the likelihood of having iron deficiencies. However, if it progresses beyond something that can be naturally supplemented with food, please send them to a medical doctor. So I've already mentioned this gas exchange. This gives us a nice picture of it, however. So what you're looking at in the picture are the alveoli. So it's a singular alveolus, and that is the smallest cell that you'd end up finding in the lungs, okay, the smallest unit. And running along beside it is a capillary from a capillary bed. So the alveoli will have oxygen in them. The capillary will have carbon dioxide, and they will exchange, where the alveoli will pick up the carbon dioxide and the capillary will pick up the oxygen. The capillary will turn the oxygen to the heart, where it will get pumped out in your systemic circulation, whereas the alveoli will take that carbon dioxide and you will exhale it. At the tissue cells, it moves in the opposite direction. So that capillary arrives at the tissue cells and it will have oxygen in it. The tissue cells will have a buildup of carbon dioxide, and the oxygen will move from the capillary into the muscle tissue, and then the muscle tissue will dump carbon dioxide into the capillary. So gas exchange is a process in respiration involving the unloading of oxygen and the loading of carbon dioxide at the tissue level for a return journey to the heart, which will then go to the lungs. In the muscle, which uses a lot of oxygen during contraction, a rich capillary supply, so that means a rich capillary bed, there's a great deal of capillaries, surround each muscle fiber. At the muscle level, the oxygen diffuses from the red blood cell through the capillary membrane into the muscle cell. And because the oxygen is going to move from an area of high pressure or high concentration to an area of low pressure or low concentration. Because at the tissue cell, the amount of oxygen in the capillaries is high, and in the muscle tissues it's low, that allows this movement. And the transport of oxygen is the reverse process. This all gets reversed at the lungs. So let's just make a moment to talk about the valsalva maneuver. The valsalva maneuver is a breath-holding maneuver, and it's where an individual will take a deep breath in, they'll fill up their lungs, they'll compress their abdominals, and they'll close their throat off. And they'll close the throat off, so they will forcibly hold their breath. Now, I'd like to point out that there is a purpose and a reason for performing the valsalva maneuver. When people are lifting extremely, extremely heavy weight, they perform the valsalva maneuver to give greater stability to their spine. So it usually sees it with deadlifts and squats, sometimes a little bit with extremely heavy bench press. So they're not doing a valsalva maneuver for bicep curls. They're doing it for these very large movements where they need to brace and bear down on their abdominal contents to stabilize their spine. So that's a valsalva maneuver. The valsalva maneuver is not simply holding your breath and not breathing, but rather it's purposely taking air in to fill up the lungs to increase the thoracic pressure, which will increase abdominal pressure, that with a contraction of the abdominal muscles will stabilize the spine. It involves closing off the throat. This maneuver is used for very, very advanced individuals. it still can cause an extreme high spike in blood pressure, which can be undesirable, especially for people with health problems. To go through life-saving Valsalva maneuver is bad and horrible. No one should do it. That would make you look foolish to completely say that. However, for the vast majority of the population, we do not lift heavy enough weights that we require the Valsalva maneuver. There are negative side effects to the Valsalva maneuver, which is that high spike in blood pressure, and also because of the intrathoracic pressure, so the pressure in your thoracic cage will go up, which will make it difficult for blood to return to the heart. There are negative side effects to the Valsalva maneuver. So for the majority of individuals that you will ever come across, you are not recommending the Valsalva maneuver. They will not be lifting heavy enough weights that they need to brace that hard. Where we also get confusion is that some people confuse Valsalva maneuver simply with breath holding. We never recommend that you would just simply randomly hold your breath when doing an exercise. Beginners you see will do this. You know, they're focusing so much on the exercise that they unintentionally hold their breath while doing it. So people will ask, when am I supposed to breathe during an exercise? The recommendation is to tell them to continue breathing. They must keep breathing. And what we usually recommend you do, you breathe during the work phase. So as you are lifting the weight, you exhale. You inhale as you lower the weight back down. So when you do the concentric muscle action, the lifting, the work phase, you will exhale, and then you'll inhale during the eccentric or lowering phase. All right, so once again, Valsalva maneuver is used with extremely advanced individuals. For the most part, these individuals will be outside of your scope of practice. You don't do the Valsalva maneuver in a group class. This is for power lifters, Olympic lifters. And so most of them will be outside of your scope of practice. So all of the rest of your participants should be breathing all the time. You never want to encourage somebody to hold their breath, because if they might have a cardiac incident, they might pass out because of the lack of blood flow to the heart and to the brain. You encourage them to breathe. They exhale during the concentric or work phase, inhale during the eccentric or lowering phase. So since we're talking about breathing, you should be aware that there are things that can affect how rapidly somebody breathes. One could be posture. So if you're sitting there right now, slump over and slouch down in your chair. You'll notice how much harder it is to breathe. Okay, so it's going to make it more challenging to breathe. You won't be able to do quite as full of breaths. So be aware of this, because especially with spin classes, if somebody's all leaned over and slumped over in the spin class or the cycling class, pardon me, this can cause issues with breathing. Also, stimulants will speed up your respiration. So caffeine, nicotine, anything like that. So somebody's drinking a bunch of coffee or smoking right before they come into class, which ideally they're not doing, it's going to increase their respiratory rate. Sedatives do the opposite. So sleeping pills, alcohol will decrease their breathing rate. And the last thing is a medical condition. It's called emphysema. Emphysema, when you saw those alveolar sacs, what happens is they get damaged. So you have fewer alveolar sacs, and so it's harder to get oxygen to the blood because you're lacking the alveolar sacs, which will allow the exchange to occur. So emphysema, people that experience emphysema, they breathe heavy at very light effort. In fact, you'll often see them seated, breathing heavy. So how can we monitor intensity? So it's very important that we exercise at adequate intensities. And one of the most popular, frequently used ways of monitoring intensity is our heart rate. We choose to use heart rate because as exercise becomes more intense, our heart rate becomes more intense. What's really happening is that as exercise becomes more intense, the muscles are requiring oxygen at a faster rate. They require more oxygen to do the work at a higher intensity. So as a result, the heart needs to beat faster to get the oxygen to those working muscles. So as workload increase, heart rate and oxygen consumption increase. So there's where do we check our pulse? So remember I mentioned about how when the heart contracts, it sends out that bolus of blood, that almost like a wave of blood goes through the body. That's what we're feeling with our pulse. There's like two really commonly used parts. the carotid pulse or the radial pulse. So the carotid pulse is on your carotid artery. The carotid artery is an artery in the neck. So it's under the jaw to the side of the throat. How I recommend you find this, if you take two fingers, your pointer and middle finger, put them at the corner of your eye, the outside corner of your eye, and then just drag your fingers straight down until they go over your jawline, and you end up nestled below the jaw into that little hollow. You'll easily find your carotid pulse there. Be careful you don't put much pressure when you take your carotid pulse. Increase in pressure can affect your what we call baroreceptors, so blood pressure receptors just below that area. So very light pressure there. Okay. The other one is the radial pulse. So remember the radius? This is the pulse near the radius. The radius is on your forearm near your thumb. So usually what I do is I go from my thumb and I just work following my thumb angle until I reach my radius on the inside of my wrist. Okay? So it's proximal to the base of the thumb. So if you take where the root of the thumb attaches to the wrist, it's just up the arm from there. You want to make sure when you're taking pulse that you use very light pressure both, and that you don't use your thumb, because your thumb has a more prominent artery in it that makes it confusing. So sometimes you'll count that artery pulse beat in your thumb. It gets confusing. So you use your first two fingers. So resting heart rate. How fast does your heart beat when you are resting, when you are not active? So average resting heart rate for males is approximately 72 beats per minute and 80 beats per minute for women. How high your resting heart rate will be dependent on things such as genetics. So some people will genetically have a higher resting heart rate. Current fitness level, as you're about to see, as you become more fit, your heart becomes more efficient, and your resting heart rate, your heart rate when you are not performing activity, will go down. Certain medications could elevate your heart rate, so especially stimulants, so caffeine, nicotine, those will elevate your heart rate. Environmental factors, so if you have changes in the heat and humidity, that could elevate the heart rate, as well as stress levels can also elevate heart rate. To really truly get an idea of what your resting heart rate is, you should really test it first thing in the morning before rising out of bed. So when you wake up, take a second, do a 10-15 second count, see what your heart rate's at. And ideally, you'll do this a few days in a row. So now, to start to get an idea of where we would, how we would create a prediction for how hard you should work, okay, when you're exercising, we need to understand what your maximal heart rate is. I make it clear, first of all, we don't exercise at our maximal heart rate, or we very, very rarely would exercise at our maximal heart rate. The maximal heart rate, your maximal heart rate, is as high as your heart can possibly beat. What's the fastest it can beat? This is done through the most extreme and heaviest of exercises. Now, the most accurate way to do this is through a graded test. They're usually graded treadmill tests. You would have a certified exercise physiologist or a certified personal trainer. They would test you. So this is when you run, this is doing like a VO2 max test, okay? Ultimate high intensity, and you would go until you could not physically go any harder, and that number would be your maximal heart rate. If you know your maximal heart rate, you don't calculate it as per your age predicted one. So most people don't have their maximal heart rate. Most people have not done a graded test. So what we have done is we have created we, meaning the fitness world, has created a way to predict what your maximal heart rate might be. So this equation that they will use is 220 minus your age. 220 minus your age. So if you are 20 years old, we will predict that the maximal level that your heart rate will go to will be 220 minus your age, which is 20. So your maximal heart rate is 200 beats per minute. This is a prediction. It is an estimate. It's quite often actually not accurate. There's a lot of problems with that equation, but it gives us a starting point. Now, using that equation, that will also show us that maximal heart rate will naturally decline with age. So even if you have done a maximal heart rate test, and so you've done a graded exercise test, after a few years, that information is no longer applicable because it will naturally decrease with age. Okay, so once again, to figure out your predicted maximal heart rate, it's 220 minus your age. Now, it's important to note we don't exercise at that. So if that 20-year-old, I don't tell them, okay, go do exercises at 200 beats per minute. Okay, that's much too high. Much too high. That's an exercise intensity that you could only maintain for an extremely short time. So what we'll actually calculate for them is a target heart rate zone. And there are going to be recommendations of what that target heart rate zone should be. And in fact, we will work our way through. And in your textbook is a chart that will tell you what moderate to vigorous activity is and what percentage of their age predicted maximal heart rate they should work at. So what you would do is you would take 220 minus your age and you would multiply it by the percentage at which you wanted to exercise. So let's take our 20-year-old again. So it's 220 minus their age, which is 20, gives them a maximal heart rate of 200 beats per minute. If I told you I want that individual exercising at 60% of their maximal heart rate, and I'll know that I want it 60% because I will follow guidelines and recommendations, which you'll see shortly. So if I want them to work at 60% of the maximal heart rate, I would times 200 by 60, which would give me 120 beats per minute. That would be their exercise heart rate. That is where I want them to exercise. Okay? If I wanted them to exercise at 70%, I would times 200, their age predicted maximal heart rate, by 70 to get 140 beats per minute. I could then further divide those numbers by 6 to get a 10-second count. So if the individual doesn't have a heart rate monitor, I would take 120, which is 60% of their max heart rate, and I would come up with 20 beats in 10 seconds because that's a quick way that they could check their pulse. So here we have it again. So target heart rate, you do 220 minus your age equals your age predicted maximal heart rate. Remember, this is not the level at which we exercise. We then take that age predicted maximal heart rate and we figure out what percentage of intensity we want them working at. So a lower limit's often 60%. An upper limit can be upwards of 90%. So if I want to do 90%, I would take 200 multiplied by 90%, which would give me 180 beats per minute. So if I wanted them to work in the range between 60 to 90%, which is a very large range, but I would tell them, I want you to be exercising between 120 beats per minute to 180 beats per minute. We don't normally give that large of a range, but that's how we would do it. And then if I wanted to get a 10-second count, I would divide it by 6. So that's why back in the day when you used to see those charts on the gym walls that would say, oh, at age 20, at a lower intensity, you want 20 beats per 10 seconds. At high intensity, you want 30 beats per 10 seconds. They just did this math in advance for us. So the age predicted maximal heart rate equate. Oh, and sorry, I should mention too, sorry. If you already know your maximal heart rate, so if you did a graded test, you don't use the age predicted number. You use your graded test number that gives you your true maximal heart rate, and then you would still multiply it by the percentages to figure out what intensity you want. So this method, if you're using age predicted, is very inaccurate. There's a lot of potential issues with it. So in an attempt to make things more personalized and more accurate, we came up, or Dr. Carvonen came up with a method called the heart rate reserve. So you'll hear this called the Carvonen method. This tries to individualize things a little bit by using not just your age predicted maximal heart rate, but also your own personal resting heart rate. And he says that your heart rate reserve is the difference between your maximal heart rate and your resting heart rate. So this is going to give us, we're going to use this formula to come up with different targets. Okay, so once again, we could determine that we want to be working at 60% of our heart rate reserve, right? So we will know what percentage we want. So you use your age predicted maximal heart rate and your resting heart rate. So the heart rate reserve, HRR, is maximal heart rate minus resting heart rate. So his formula You will determine in advance what intensity you want the individual working at, and you will multiply that by their heart rate reserve, which is their maximal heart rate minus their resting heart rate. When you have that number, you add back in your resting heart rate. Don't panic. We're going to go through an example. And truthfully, when I calculate this number for clients, I just usually have a formula in front of me so I don't trip over things. So going into this equation, we would not need to know your maximal heart rate as well as have tested your resting heart rate. So let's take the example. Okay, we're going to figure out their heart rate range, and this is going to be for an individual that's 32 years old who has a resting heart rate of 80 beats per minute. They have told us, and once again, you'll see shortly the charts that will show you where you want individuals to exercise at. But there, for this example, are telling us that we want to give this lady a range in which to exercise, and we're going to say the lower intensity will be 50% of our heart rate reserve, and the upper limit will be 75% of our heart rate reserve. So to do this, we're going to need some information going into it. We'll need to know what her age predicted maximal heart rate is. So we know that's going to be 220 minus her age, which is 32 years old, which gives us 188 beats per minute. That's her age predicted maximal heart rate. She does not exercise at this because this is the level where her heart couldn't go any faster. We have been told that we have her resting heart rate of 80 beats per minute. And now we're going to figure out their desired percentage intensity. So we do percentage of intensity multiplied by your heart rate reserve. Once you have that number, you add back in your resting heart rate. It's very important that you do that first step before adding back in that resting heart rate. This is where people go wrong. So you do percentage intensity. We've said that's going to be 50% multiplied by your heart rate reserve. So in her case, that's 188 minus 80, and then you add back in 80. So when you're looking at that equation, you want to do 188 minus 80 to give you 108. You are going to multiply that by 50%. You'll take that 50, so that should give you 54, and you will add 54 to 80 to give you the number of 134 beats per minute. It is extremely important that you do this in order, because if you try to add things in too soon, you get odd numbers. Okay? And you could do that exact same thing now at 75%. So this is going to give her 161 beats per minute. And there you have your answer. So I would say to my client, I want you exercising between 50 and 75% of your heart rate reserve. So when you're doing your cardiovascular exercise, I want your heart rate to be between 134 to 161 beats per minute. Or we can do a 10-second count. So I would simply take those numbers and divide them by 6, because there's 60 seconds in a minute, which will give me a 10-second count, which would give her 22 to 27 beats. You need to calculate this before activity. So they would go in. So usually if I was consulting with personal training, I would calculate this. They'd be sitting down, I'd get their resting heart rate, I would do these calculations, and I would give them the number and say, exercise in this range. And I encourage you right now, I would honestly pause the recording, and I would calculate this yourself. Okay? Our heart rates will naturally decline with age. So if you are a lot older than 32, odds are quite strong that you will end up with a target heart rate of a lower number. If you're younger than 32, the odds are quite strong that you'll end up with a number, an exercise heart rate higher than what this individual has. There is a little bit of a difference in there because resting heart rate's taken into account, but for the most part that'll be a trend because our maximal heart rate naturally declines with age. So I'm going to differ a little bit about this. Here they're saying it's challenging to calculate heart rate in a group class setting. Although it's easy to check pulse, to do the calculations are hard. That said, if an individual goes, so I agree, I will concur that if I went to an exercise class and in the middle of the class I had the individuals calculate what their target heart rate should be, that wouldn't work at all. However, if an individual goes into an exercise class already knowing what their target heart rate zone is, they could quickly do a 10-second count to confirm that they're in the range that they want to be. So in that last example, I think her 10-second count ended up being 22 to 27. So if all of a sudden in that 10-second count, her heart rate's up closer to 30, well, we would tell her she needs to ease things up. Or else if during that 10-second count, her heart rate is down at 18, well, we tell her she'd have to work a little harder. Okay. Um, they do mention very correctly that heart rate is not a perfect measurement, especially when you need to use the age predicted equation, the 220. So both Carvonin and your maximal heart rate percentage, both of them, if they use age predicted maximal heart rate, there is a great range of error in this. It is very common for people to have a true maximal heart rate that's 10 beats per minute faster or slower than what the age predicted formula. So this is not perfect. Heart rate is not perfect, and plus we've already talked about it. It can be affected by stimulants or relaxants. It can be affected by different things. So it's best to have an arsenal of different ways to check. So it's not like we can't use heart rate, but let's check other things as well, which we're about to discuss.